NeuroCentric approach. And we are live for the weekly NeuroCentric approach online academy case conference. Welcome in, folks. While folks are coming in, we're going to have some fun this week talking about aging. And I'm going to be somewhat self-revelatory. I hope to stop short of being accused of narcissism. But yeah, some funny intersections of aging processes occurred both personally and with patients this past week, and I thought it would be kind of interesting, if not fun, to discuss and weigh in on. For those of you over here that are not part of the online academy, the NeuroCentric Approach Online Academy is online continuing education, PACE accredited for chiropractors in the US. And we've got 35 hours there, and currently you can pay by the month or annually at this point to get access to that. Periodically, a few times a year, I open the platform up to a single payment for a lifetime membership. That's one payment. You get me for life. What do you get for, whether you like it or not? What do you get for that? You get, in addition to that current online academy reservoir of 35 plus hours of continuing education, you also get $100 off of all of our in-person courses when we have those. The next one is going to be right here in Portland on the 20th and 21st of April. We're just over 1 month out now. That's going to be the upper quarter course, 12-hour course there. We have courses in the mix right now, trying to get dates and times and locations formalized for St. Louis, for the Fargo area, and for Toronto, and also for Phoenix, and possibly for Austin as well. So we will keep you posted on all of that. While folks are coming on here, this particular weekend in Portland is absolutely frigging gorgeous. It's that, lovely weather we all look for in the Pacific Northwest after a long winter. We're looking at hitting 70 degrees today. That's 20-ish Celsius for those of you north of the border and beyond. And that also means the pollens are out. The pollens, for me, that I seem to be responsive to, despite all of my efforts otherwise over time, are alder and poplar, and they are up in force today, peaking over 10 in our area. So what that means to me, I mean, Candy, I wouldn't have even noticed that that was an issue that was going on, except for my eyes. And my eyes have just been, goopy and really scratchy when I spend much time outside. And the other place that I notice it is on my data, my Aura Ring. I've been tracking lately because I've been pushing my running mileage distance wise and my HIIT workouts up a bit, trying to see how high I can get my VO2 max at my nigh unto 61-year age. Apple tells me I'm in the um, the 30th percentile and the highest grade of physical, their way of rating VO2 max and physical cardiovascular health. And I'd like to get up into the mid range on that. I have no idea what my VO2 max was back in the day. God, I hate saying stuff like that, but it's so much more applicable. So the eyes, that got me kind of thinking about eyesight and these standable glasses and stuff. My eyesight over the years has been really, really good. I was blessed with very good vision. I had 20/10 vision for most of my life. And then, like many of us, the presbyopia set in starting about 10 years or so ago. And you can track that back. I can remember a specific continuing education course I was at. Seth Will and I were sitting next to each other in the back, and I had had to wear readers to see the material, and that was humbling. So my eyesight now, I just tested recently when my son was here, just doing a Snellen test and informally, and it looks like I'm probably going to be needing some sort of graduated eyeglass material here. So that might be something you'll see that's different in the not too distant future. And I also saw a very funny video that hit way too close to home this morning on Facebook Reels from some guy that did a rap on regarding readers. So it was kind of interesting. So that, you may wonder, why the hell is this boomer over here waxing on about this stuff? If you're not a boomer, this is uninteresting. I completely appreciate that, but you'll get yours. The other place that's leaned into this week has been about tendons and aging tendons. I've been, I won't say sitting on, I've been stirring consistently on a simmer the pot that is the ideas that I'm working with about how NeuroCentric approach can be applied to tendinopathy conditions, and how and even if the model fits when we lay it down on what we currently know from the evidence base about tendons when they don't heal properly. And the reason, the intersection there with aging is because the risk factors for developing tendinopathy increase as we get older. And that is similar to the stuff that you've seen me talk about in the past about disc degeneration. And then it's always fascinating to me to see the younger pundits on social media and such weigh in on that. And it's like, oh, this is just normal aging. Well, everybody doesn't age at the same rate, y'all. Some people live a little harder life, and some people have different genetics. And then those people with the combination of that, say, hard living, which we could also re-express as epigenetic factors associated with turning genes more commonly off, methylation process of various genes associated with aging that you might genetically have. The turning on and off of those genes has a lot to do with how quickly that aging process happens to certain tissues. Tendons are one of those, discs are the other, and the commonality between those structures is the avascular component. In that avascularity, the the spinal intervertebral disc, the nucleus pulposus area combined cumulatively represents the largest avascular compartment in the human body. It has an entirely different homeostatic um, uh, capability from other parts of our body that are better vascularized. But the type of homeostasis that occurs there, namely, one of the key things there is currently, I think we've identified 24 matrix metalloproteinases that help to regulate extracellular matrix production, turning it on or off. You've got your clasts and blasts of different kinds, like what you learned for bone remodeling and such back in the day. But mostly those are tenoclasts in these cases and tendons. Um, the You have a similar kind of situation in tendons that you do in a nucleus pulposus. And the evidence also intersects at discs and tendons in terms of loading. So when we have an aged tendon or an aged, we'll call it aged and quote unquote pathological tendon, and an aged quote unquote pathological disc, then loading strategies are important because we can make those structures more resilient to life and load and experience by loading them effectively. The question is, how do we load them? And when do we load them? So, back at the risk of being self-revelatory, ways that this have been a little more notable in the past week regarding eyesight and tendons in yours truly. I showed these at the beginning of the episode. So you can see the potential hilarity that could ensue from a mix-up of those two products, right? So, aging in men, prostate. They get bigger, y'all. And that narrows the urethra. I remember laughing really hard years ago about animated show that was talking about this and having a narrowed urethra. And at this particular point at 61 and dealing with the foibles of that, it ain't a hell of a lot of fun. And as a result of the extra pushing on that, yours truly developed a hemorrhoid. And then I had to play with a little hemorrhoid cream. So that's been sitting up there on the counter in the bathroom, mocking me on a daily basis. And then recently, capsaicin cream. Capsaicin is an agonist of TRPV1 receptors, which exist on nociceptive neurons, sensory neurons. And those receptors tend to be upregulated when those neurons are irritated. And if you've had a nerve injury and perhaps some hypersensitivity of a nerve area or a dermatomal field, then you can apply capsaicin lotion like that on a regular basis to downregulate the TRPV1 expression on those nociceptive neurons and those sensory neurons. to reduce the sensitivity of that neurology. And I have been applying that on a heel that got the crap beat out of it on a long walk I took last year on the Camino. And I've still got some residual hypersensitivity on that heel and around the Achilles associated with that. So I've been applying some in anticipation of a walk that my wife and son and I have planned, the Via Francigena, from Lucca, Italy to Rome, Italy in June. So fair warning, I'm not going to be on here for these meetings in June. We're going to do that for I think we're on trail for 9 days, and then we're going to go to Morocco for a couple of weeks. So that I got to prep my leg for that. So I've been putting the capsaicin cream on that. And I put the two tubes up on the kitchen, the kitchen, no, the bathroom sink, to remind me to regularly put these things on so that I can have both of these problem areas addressed regularly and try to get a therapeutic effect. And I joked to my wife that wouldn't it be funny if I mixed these up? Well, that happened, y'all. And I'm here to say this is why we trade. Yeah, last night we came in from a dinner out with my in-laws and had a lovely time and kept my alcohol consumption down to 1 because I don't drink much anymore, but came in a little bit late and decided to go to bed. And I apply my ointments at bedtime, and I realized, yeah, I'd made the mistake. So again, this is why we train people. So who knows, maybe capsaicin on a hemorrhoid will reduce TRPV1 expression on rectal nociceptors, and my hemorrhoids will get better. Stay tuned. I'll let you know. But it was much better after a nice hot shower with soap. Okay, so self-revelation. I'm starting to feel like Theo Vaughn here with some of these uncomfortable confrontations that we're dealing with. And then how does that lean over into my own aging tendons? I had an MRI yesterday on my left shoulder. If Dr. Corey Peterson, one of my former associates, happens to watch this at some point, he's not on here live today, but he'll recall that about 10 years ago or so, after a foosh, fall onto an outstretched arm on my left side in an icy mogul field, I believe we were at Whistler. In addition to the stinger that I got in my neck, I also had a rotator cuff injury, and some of the worst pain that I've experienced, an acute tear on the rotator cuff. No, it wasn't Whistler because we flew back home, and on the way home, I fell asleep leaning next to the window with my elbow on the armrest, and I awoke. I just about howled in pain due to the pain in my shoulder. And I subsequently, with Corey and my other associate at the time, went to Dr. John Parker. I went to University of Western States to their relatively new ultrasound imaging program. And I had the head of the imaging program to do an ultrasound there, and she diagnosed me with a grade 3, excuse me, not a grade 3, a full thickness tear of the supraspinatus tendon. And I was like, damn, that's likely to need a surgical fix, and that's going to put me out of work for a while. And I am not willing to go down for the count for a while. I wasn't in a good position to be able to take that kind of break. So I'm like, well, I'm going to do my level best to rehab this. So I took out my kit bag, my meat-based tendon rehab protocols, and a lot of that involved just loading strategies progressively from isometric to slow isotonics to isotonics to power. And the first, initially I couldn't abduct above 15, excuse me, about 15, 20 degrees before I'd run into pain. So it was really crazy tender initially, but I steadily worked at the edge of what I could do. And to work on stabilization strategies, I used a labile tool. I think I just used something like a Boeing or a body rod, those body blades, something like that I had. You can also just use a bottle of water that you swirl the water around in. It doesn't take much. And some guys out there marketing a device on social media now that just takes a little spinner on the end of a rod and helps to improve stabilization. It's just a sensorimotor challenge to get you engaged core. So that's a sort of a call it a regional interdependence model, or even a DNS kind of proximal stability before distal mobility kind of framework. So, in this particular case, I over the course of 3 days, I steadily worked back into a range of motion, and it only took me 3 days using isometrics to get myself to full range of motion in my shoulder with very little pain. And I was like, well, damn, that would suggest that was not a full thickness tear of the supraspinatus. So that cast some doubts in my mind on the veracity, one, of ultrasound, and two, to discriminate between those tendon tears, and two, between the people that have experience in reading ultrasound and using ultrasound. And this is germane because you see a lot of people in our world these days with the advent of little ultrasound machines, pulling them out and charging people for it, or using them for marketing purposes and this, that, and the other. And I'm here to tell you that it matters how much you've used that and how much you've been exposed to it. And indeed, the evidence bears that out on me, because I just looked that research up today, and a most recent review done just last year shows the sensitivity and specificity of ultrasound in diagnosing rotator cuff and distinguishing between grade 2 or full thickness and partial thickness tears in the rotator cuff is well above 90% for both sensitivity and specificity, but that the ability to discriminate between those varies greatly, dependent on the experience of the operator. So there's a little clinical nugget for you guys, that if you are wading into this, trying to educate yourself on how to use ultrasound, do take it with a grain of salt. You probably don't know as much as you think you do. Two, you should probably find people in a physical medicine space in your community that have some expertise in this, and look for the longer tooth people rather than the young guns on this. And three, something that we should consider as well is a bridge between those two. There are companies that are leveraging AI in this space for these small units, and the evidence is still being generated on how well those programs, so that it basically removes a lot of the potential operator error here of just allowing the program itself to be able to do the work for you there on doing the discrimination for those. So I'm on the bubble on that about whether to consider that for clinical usage. But my MRI was done. Why did I do an MRI? Doc, you're supposed to do all these things. You make shoulder courses about nerve involvement on MRI. Yes, I've done all the nerve things. Sometimes, remember, in the shoulder especially, the nerve things cause a change in motor behavior according to our NCA model. And that change behavior elevates the shoulder and pitches it forward, and that narrows the subacromial space and predisposes the rotator cuff to more injurious forces. And those injurious forces are probably more on the articular side rather than the bursal side of the tendon, and probably have less to do with the actual pinching of the rotator cuff, and more to do with the way that biomechanical position alters the compressive forces on the underside of the tendon, because most of those tears occur on the underside of the tendon. They do occur sometimes on the bursal side of the tendon, but I don't know where mine is yet, and we won't know that probably for another couple of weeks, given the timelines of Kaiser these days, which is where I got my MRI. I'll let you guys know about that. So the thing that I've been dealing with, and the thing that pushed me after, I would say, relatively successfully rehabbing this over the course of the past 10 years and keeping it relatively high functioning, is that I've had some restricted range of motion in that shoulder. Initially, I had too much movement, and then I think my body stabilized it. And it stabilized it in a position by causing some chronic tightness in the pec muscles, which then subsequently caused enough compression to give me some intermittent paresthesias in my fourth and fifth fingers, and some intermittent issues associated with the ulnar tendon around my elbow as well. And I have been growing, kind of frustrated over a 10-year period of that body imposed stability and then the fallout from that. And recently I decided to try some calisthenic movements and lean into body weight stuff. And I started off with all of my DNS closed chain movements and all of my pointy hat, egg-headed things. And then I started to move over into gymnastics-based movements using parallel bars and working on crow pose from yoga, and in addition to crow pose from yoga, that swings through from crow pose to an L-sit position, and I was just working on that transition. So that's my full body weight on a straight arm through the shoulder, working into a rotary movement, and that was enough to certainly break up any adhesion process that I had in my subacromial space. And yeah, I got more mobility back in my shoulder, but it hurt like a son of a bitch. And since then, and now for about a 2 month period, unsuccessfully trying to get the subsequent clunk and catch in my shoulder movement, which has been so painful that I can barely load up into a side posture movement for a manipulation. I have uh, decided that maybe it's time to consider going in and surgically cleaning that up a bit. The research on that for partial thickness tears and even full thickness tears on the surgery is actually pretty darn good when you track it out to 2 to 5 years. So what I'm hoping for there is that I'll be able to get appropriate range of motion, better integrity on the tendon, some reduced instability in the shoulder joint. And my longer term goal for my health promoting aspect is to improve the risks associated with sarcopenia in my upper body, because right now I can't do an upper body workout. And I can't pull and can't push. And in all planes, all I can do is deadlift to load the shoulder. So I've been deadlifting more and been focusing more on leg workouts and stuff. So that is the aging as it pertains to tendon discussion this week. And before I move on to case study, which leans into this aging process as well, I want to open up the floor for any questions. Anybody have any questions or comments? Mark Eller says, have you tried shockwave? I have not tried extracorporeal shockwave on my shoulder yet. I have been, you're correct. There is some decent research. The thing that bugs me about the research on that, Mark, is nobody seems to know what the hell it's doing. It seems that even when you get to the specialist, and the specialist meaning the actual surgeons looking at it, they seem to look at it and say, yeah, it seems to be doing something, but we don't know what. And what I also see very close to me, Chris Duffin's got one. He doesn't have one of the higher strength ones, the focal units, but he's been toying with it and has seen some interesting things as well. And I know that our joint friend and colleague Warren Hammer thinks highly of it and has used it in practice. But I'll be candid, the big limiting factor there is, from what I understand, the ones that are more focused are the ones that have the compelling evidence on it. And from what I understand of those, the costs of those run upwards of $30,000. And I don't see enough clinical benefit in the research to warrant pushing me in that direction yet. That's where I've been so far. So convince me otherwise, brother.
I'm not saying go buy a machine. I'm saying go find a practitioner who's experienced in it, probably a chiropractor, who has a focused shockwave machine. I'm fortunate enough in my office that Rachel Knight, the chiropractor who works with me, has been doing shockwave for 8 or 10 years now. And we have both a focused machine and a radial machine. And I think it does wonderful things. And, before you consider surgery, you should absolutely consider modalities that may stimulate healing, which would include focused shockwave, would include PRP, So those are all available to you, and none of them will knock you out of work for 6 or 8 weeks, unlike surgery.
Yeah,
So anyway, just look at it. I mean, you could even make a trip to Ashland, and I could do a couple of shockwave sessions on you down here.
it's funny. It's funny you say that. I may very well take you up on it because I was just thinking the other day that I'm about ready with when this weather gets nice like this. One of the things I particularly enjoy doing is going down to Ashland and taking in a play at night when I can sit outside and not, worry too much about getting rained on. Yeah, in regards to that, Mark, and thank you for the weigh in, and thank you for the. I think an invitation was incorporated into that, and if it is, then I may take you up on it. But the that kind of leans in and provides a nice intersection with the case study here, which I will be more forthcoming about in a moment, unless we've got questions in one of these areas, either over here on Zoom or over here on Facebook. Anybody got any questions or comments? The difference between focus and non-focus shock wave, that's the question from James Edward Gordon. James, I'm going to leave you to a little bit of Googling on that. You'll be able to get that probably. I'm not, it's not an area of expertise that I have. Not, so I don't feel comfortable weighing in and trying to, you know, pretend that I know more than I do on that topic. So let's both do a little Google search and see what we learn. Any other questions or comments? Okie doke. So the case study that I've got is actually a patient that was shared with me, and this is the intersect, Mark, between one of my one of the better known local pain interventionist radiologists. And I've been tracking this guy since he landed in Portland in 2008 and have referred several patients over the years when I wasn't able to get them to the point that I needed them to be at or they needed to be at with my conservative measures. And I respect his work. And the patient actually wasn't referred from his office. The patient found me online from an article that I'd written. The patient that presented was an 82-year-old female with severe, very specific pain in her buttock. So she had been diagnosed with a stenotic process in the lumbar spine, which had been addressed surgically. And the stenosis was cleared. She had the pre and post MRI that clearly showed that there was more space for the involved neurology. The involved neurology was at L5S1. And also she had some involvement at L1-2. And you guys that have been paying attention on some of these know that as we get to a more advanced age, especially in a female population, and have the greater risk of insufficiency fractures from osteoporosis, they typically occur in the upper lumbar spine. And when they have that, which this patient did not, but when they have that, that does increase the risk of a involvement of the superficial neurology that comes off of that particular area. And among those are the superior cluneal nerves. So superior cluneal neuralgia is the prevalence is about 60% in females with those kinds of compression fractures. Again, this patient did not have a compression fracture in the upper lumbar spine. But she found me online because of some articles that I've written online about cluneal neuralgia. And she lives about an hour south of Portland. So contacted me to come up and see what we could find out there. And it was interesting because she provided me with her pre and post MRI reports, and she provided me with the notes from this pain interventionist physician that I mentioned. And I had a roster of the procedures that had been done on her for the past 18 months after her surgery. So she's been living with pain for 18 months. That's at baseline 6, and that's if she doesn't do anything. So I've got an 82-year-old whose only way of staying out of pain is to sit in a chair. And you guys know that is not a good mix over time. And she knows that. Very bright person, retired school teacher. Very organized in her presentation. Everything's nice and laid out. You got to love those patients when they give you that. And her list of the procedures from the physician, it was his list. They did joint blocks at all of the posterior elements, the facets on the lumbar spine. You get a little bit of benefit here, you get a little bit of benefit there. They did epidural steroid injections. And mind you, her symptoms that she got surgery for were all on the left side. And after the surgery, directly after and persistent for 18 months, she had total resolution of her radicular symptoms in the left leg. But she had, from the moment of surgery on, she had right leg symptoms. And the symptoms in the right leg were consistent with a radiculitis, and the injections that were done at the epidural, for epidural steroid injections, resolved those symptoms of radiculitis further down the leg. But she was left with this baseline 6 out of 10 pain in a very focal area in the upper buttock on the opposite side, the right side. And the bless his heart, the physician actually injected there, and they got benefit for about 3 days, but nothing else was done. And so they theorized a potential cluneal neuralgia and injected it once and had observed benefit and then did not follow up. The research on cluneal neuralgia, most of it's been done by physiatrists, most of them in Japan. And, when the way you address the world is with a hammer, most everything looks like a nail. And physiatrists, in the analogy there, address the world mostly with a needle full of some kind of cane, procaine, marcaine, bupivacaine, whatever. And those various canes are nerve blocks, typically of some sort, either just articular sensory neurons or to nociceptors of some sort. And in her case, the injection did give temporary benefit, but the research on that says that if memory serves, in their patient population, upwards of, I believe, about 120 patients, they had very close to 100% improvement after 3 injections performed weekly of lidocaine in that particular area. So I'm thinking that might be a good way of going. But the patient's sitting in front of me and I don't inject lidocaine. So I place her on her side and attempt to do the work that you've been shown in the coursework online and in the in-person courses. That basically is a combination of DTM, dermal traction method, and TNM, that's transverse nerve mobilization, to affect the mobility of the superior cluneal nerves. And in this case, palpatory findings perfectly reproduced her symptoms over the medial branch. Remember, there's 3 on each side, over the medial branch of the superior cluneal nerve on the right side. Now, those of you that are chiros that are watching this, that branch is the most common one that is affected from the superior cluneal nerves, and it is so frightfully close or overlying the SI joint that many of you that were trained to do various SI joint maneuvers or motion palpation and stuff, you will note that you're putting your friggin' hands right over the top of that nerve and the middle cluneal nerves and pushing down on a putatively pissed off nerve while you're trying to assess and evaluate that joint. Doesn't mean that the SI joint can't be a source of nociception, but you need to factor that overlap into your assessment and make sure you're not dealing with that. Now, dealing with a nerve problem instead of a joint problem. So in her case, skin rolling over that area was painful. Palpation of the nerve itself, both directly over the iliac crest, proximal to that, or superior to that, where the hiatus is, the grommet, if you will, in the thoracolumbar fascia, distal to that, where the second most common area of entrapment, which is the tendon of the gluteal muscles, right at that point was particularly tender on her. And she had noted as well that her symptoms in that area got remarkably worse in her physical therapy when they did gluteal strengthening exercises. And those were performed both open chain and closed chain. So she was doing bridges and side lying things that looked like variations of clams and lateral leg raises and such. So in terms of clinical reasoning, I now know the tissue that seems to be the cause of her persistent 6 out of 10 pain. The question is, am I going to have any clinical effect doing the manual therapy stuff that I'm doing? Now, mind you, the cane that someone might inject there, in addition to having an effect on the nerves, it also has a mechanical effect locally. And there's other research about this condition and other superficial nerve entrapment and peripheral nerve entrapment conditions that show that when the nerve is entrapped, when the nerve is entrapped, that you will have a blanching of the nerve in the provocative positions, and that when the mobility of the nerve in that entrapped condition is improved, the blanching of the nerve in the provocative position is not there, and the pain goes away. So you got an association between blood flow and pain there to the involved neurology. And others in the injectate treatment modality for cluneal neuralgia have tried just injecting normotonic saline, which is referred to as hydrodissection. And I know one of my colleagues, Cairo, that I graduated with, practices up in Washington, that subsequently went back to school and got a degree as a nurse practitioner. Most of his work now is on doing hydrodissection around these kinds of nerves. Almost makes me want to go back to school and get that degree myself, and to be able to have that as a way of possibly helping patients a bit better. But where we are right now in the evidence base, there is no evidence, published evidence, to support what I am purporting we are able to do using DTM and TNM. So you're only relying here on my clinical experience and others that have been doing this. And what I would estimate is that I have probably somewhere in the 50 to 70% success rate on that particular condition using a combination of DTM and TNM in clinic with a home exercise program that involves dermal traction method done several times daily, and certainly when the pain comes on. Mark posted a question in the chat: where do you apply TNM for gluteal pain? That all depends on what the source of the gluteal pain is, mate. As you recall from the lower quarter course on that, gluteal pain of nerve origin could potentially be cluneal nerves, superior cluneal nerves, middle cluneal nerves, inferior cluneal nerves, and then as we go deep, potentially inferior gluteal nerve and superior gluteal nerve, although those are less common because they're mostly motor. Although the superior gluteal nerve, with that transverse process, moves laterally and then provides sensory, articular sensory to the bursa and elements of the posterior hip capsule. The sciatic nerve itself can be tender to palpation in that area. And the sciatic nerve in, I believe, if memory serves, about 25% of people also provides articular sensation to the posterior hip joint capsule. So if I'm thinking nerve, it could be all of those. It could also be a gluteal tendon. So where I would apply TNM, which by definition would mean I'm addressing a nerve, it would be whichever one of those neural structures seem to present both on history and physical examination to be that particular nerve. And then TNM, you have to understand the typical anatomy of the nerve's path. And if the nerve goes this way, your TNM tries to work perpendicular or transversely to the path of that nerve. So I would get on one side of the nerve and try to push it in one way, and then get on the other side of the nerve and try to hook it and pull it in the other direction while the patient is moving. So in this particular patient, she was side lying, and I first, working superficially to deep, use DTM to kind of grab and lift the tissue over the involved area, working from superior to inferior and vice versa, while she alternately flexed and extended the hip, both actively and semi-supported. And we got what I was testing there was how tolerant the nerve was to intervention. The nerve is irritated, and if I go in and immediately start banging on it, do I, offer any significant benefit there? Or if I put a bunch of cross fiber friction, do I provide more trauma to the area or not? And Mark also asked, do you do joint mobs or manipulation to the upper lumbar joints? Yes, she got mobs and manipulation to that area. And do I activate the abs to quiet the TL myos? Yes, that too, looking at it from a regional interdependence and DNS process, that's mostly going to be the next visit when I see her actually on Tuesday. But that particular work is more for the long term. First visit, I'm trying to make sure that I'm on the right tissue and I've gotten some sort of benefit to the irritated tissue. And then the second visit, I usually lean in a little more aggressively into the functional stuff for the longer term. So I did my DTM, and her index was walking 20 yards. At least when she presented, she said, and her husband who was with her said, she had a consistent 20-yard walk from the living assisted community that they live in, from her room to a particular area in the facility where she would start having a worsening of symptoms in. So before we started our treatment, I stood her up and we walked out into the hallway, and we walked 20 yards and she didn't have pain. So we walked until she had pain. And she actually had about 3 times that in clinic at that point. And she noted, well, I've been sitting on my can for the last 2 days, not doing anything, trying to make this better. And it probably had a benefit. And, some might ask, well, why don't we just sit her down and let her stay down for a good long period of time? She's kind of done that off and on for the last 18 months, and that doesn't have a good long-term benefit. So that's why I wouldn't do that for the long term. Short term, maybe, yeah. So I did she had about 60-yard tolerance. After I did the DTM, she had about 80-yard tolerance to walking. And then I did the TNM, and mind you, I didn't even mention, she walked in wearing a stabilization brace on her right knee because she's scheduled to get a right knee, or she's on the bubble about getting a right knee replacement because of severe osteoarthritis. I didn't lean into that at all until we'd done something with her upper back and her presenting complaint in her hip. So then I did the TNM, inside lying position, the contacts, as I just mentioned to Mark here. And then we stood her up. That was quite painful, by the way. Stood her up. We went out and walked, and she walked over 100 yards with no pain in the hip. And she had to stop them because of pain in her knee. And the pain in her knee was on the medial aspect. So where do you think I went? I went to the saphenous nerve and did some saphenous nerve mobilizations using DTM and showed her how to do that. We walked another 100 and then 120 yards before she had appearance, not of her buttock pain, but of the knee pain. And let me move over to the nice email I got from her later this week. Yeah, she says, we had talked about the possibility of conferring with her pain interventionist And as it happens, he's in a part of town that I would like to have an office in. And I've been meaning to reach out and contact this guy. So I said, "You mind if I talk with him about your case?" So I sent him a note at the end of the visit, just a simple one-page note. Again, guys, don't give detailed notes to your specialist when you send them out and give them information about what you've done. And you don't need to, use terms like dermal traction method or neurocentric approach. You say use the manual therapy approach to create some space around a particular nerve, and that seemed to show some promise. And tell them what you did, and then let them know you're going to keep them in the loop about what you've done, and thank them for their participation in working with them. I did exactly that, and I got a return message later in the day from someone in the office and say, "Hey, we want you guys to come out and do lunch with us." So I'm going out to that particular office. Well, guess what they do, Mark? They also do extracorporeal shockwave therapy, and they do PRP injections. So we'll see what I can finagle out of all of this. But in this particular case, the patient emails back and says, "FYI, the next day I had less pain in the buttock and iliac crest than I've had in 9 months. It was worth a very long drive to Portland. Um, I had previously scheduled a follow-up telehealth appointment with the pain interventionist, and he said two things. He said, one, I personally, Philip, are welcome to come and observe anything he does to her in the clinic. And he's looking for someone to rent a space in his office. So who knows? That might open up some doors there quite literally. And Dr. Johnson and I are going out there soon." She said, "You also mentioned that you had a video course regarding cluneal neuralgia that I could perhaps pay for that might be helpful." And she asked for a link. That link, for those of you that are interested in such things, if you go to the Leap, LEAP, or just Google the Leap, cluneal neuralgia, and my name, you'll get that. I think it's got a $20 price point on it, and it's a nice little thing that was made for an entry point, both for clinicians, therapists, and patients to use. And it's also on the NeuroCentric Approach site. I've got a spot there called Nerve Snacks. And I'll be making more of those over time to both help people in the general population that are looking for self-help solutions to these kinds of neural entrapment issues. And in this particular case, I've got one for saphenous nerve and one for cluneal nerve. So there's our case study and some interesting life experience, aging, this getting older stuff. It ain't for sissies, people. But you heard it here first. Keep your capsaicin ointment and your hemorrhoid ointments separated. Okay. Anybody got any questions, comments? If you're in the Pacific Northwest, go out and enjoy the beautiful weather. It looks like Mark is out there with his wife, Beth, enjoying that time right now. I'm going to go out and enjoy a nice long run with my doggy and then maybe a long walk, but somewhere in between there's going to be a lot of quality time with a power washer to take moss off of a variety of things as it accumulates during the winter here. Questions, comments? This will be the recordings of this posted on the blog at neurocentricapproach.com. You guys can see all of the previous ones there as well and kind of sift through stuff that you find interesting or not. I hope you some of you will come join us. I know Mark is, but the rest of you will come join us at our next in-person course, April 20 and 21 at Evolution Healthcare and Fitness in Portland, Oregon. You're welcome, Mark. You guys take care. Be well, stay curious, stay consistent, remain compassionate. Those are your 3 C's. Take what you learn, leverage it towards your patients to help them feel better, people. I respect you and hope you do as well. Be well. I'll see you next week.